my mic on. Good afternoon, everybody. We are waiting on members to come. We are a bit short, so we'll be on pause till we get a quorum. Okay, everybody, we now have a quorum. Good afternoon, everybody. It's nice to see everybody again. This is our first meeting. I have a new secretary. She's not with us. Her name is Audrey, in case anybody's trying to make an appointment with me. I will tell you that if Matt Hatchett steals one more of my secretaries, his life will be in danger. You know, that would be the third time, so Audrey is going to be a good replacement. I've had good secretaries, and so she's over in there working. We have a new attorney that is helping us now that Betsy is running the whole legal department. Claire, raise your hand. She's over there. We're glad to have Claire with us. And sitting by Claire is Leah. I think she's sitting, there you are, Leah. Okay, I didn't see you. Leah is a senior at Georgia State and is my intern for the session. And wherever Kim is, there she is back over. Kim is my outside assistant that I hire to come back and help me, and this is her 7th session. So some new, some old, and if you need us, we're in 436 in the Capitol. We are still operating under the rules that we passed for the first session. And if you need to review them, if they're not in your folders, we'll get it for you. And with that, I am going to start the meeting and call on our Speaker Pro Tem to come forward with House Bill and present House Bill 1010. Madam Speaker, wherever you're comfortable. Will.
Well, thank you, Madam Chairman and members of the committee. I'd like to ask for your consideration of House Bill 1010. In 2021, the state passed, the legislature passed, we implemented the first paid parental leave in Georgia, which was 3 weeks. To be honest, I was surprised we didn't have any. I didn't know that previously. Shame on me. And I thought 3 weeks was a great start, but I did not think it was adequate following the birth of a baby or the adoption of a baby. And so I started looking at this over the summer. Georgia's the largest employer in the state of Georgia, so I looked for like-sized employers, our larger corporate employers, to sort of benchmark where we were. And most of them offer some iteration of 12 weeks. And I thought 6 weeks would be a compromise between 3 and what the larger employers and also small employers offer. We researched it through House budget, and there's about 300,000 state employees. About 170,000 of them are teachers in the school systems, and the state does offer the opportunity to purchase short-term disability, but that is primarily to the 130,000 state employees. Only 11 school systems offer short-term disability that someone could purchase, and that only applies to the birth mother, would not apply to any other parents, including adoptive parents. And so in this day and age where most women are working and families have a lot going on, I think it is a needed investment to make in our employers as the largest employer in the state of Georgia. Put in within the context of FMLA, the federal law, very few to no employees are coming back after 3 weeks. So if, for example, a school system has to make an accommodation by hiring a substitute teacher, they're already incurring that cost. We're just asking the parent to work without pay or to use their sick or annual pay, for vacation. That frankly, those of you who are parents realize most parents need that because the first year of a child's life, your child is usually sick a lot once you put them in child care. And so Christine Murdoch, head of House Budget, felt the cost was minimal in terms of the additional burden on the school system or the state. She actually polled how many employees per school system, how many of their total employees actually used maternity leave, as I said, up to 3 weeks currently, or unpaid or using leave, and it was a minuscule number. So it doesn't affect them in terms of most of their employees are not having children every year, but I'll tell you, if you're that employee, it means a lot to you after the birth of a child, which is an enormous, I think the greatest transition that a family endures. And so with that, I'm happy to answer any questions.
Thank you so much for bringing this bill. This is a really important step in the right direction. 2 clarifying questions. So this is paid leave that can be used by either parent if it's a 2-parent household? This is for 6 weeks of paid leave. Is it possible that if it's a 2-parent household that they could actually stagger their leave to get closer to that 12-week norm that you've seen?
It is.
Great.
I mean, currently, it's not that many employees of the state that are both work for the state. We probably all can think of one, but it's very few. They can take 12 weeks now unpaid by federal law. So they could get to that if they wanted to. They could take it concurrently. They could take it separately.
Great. Thank you.
Great question. Representative Hilton.
Thank you, Madam Pro Tem. Again, clarifying question. Is there a period of time the employee has to be with the state to be vested or to receive? For example, could they, 3 days in the job, is there a period of time for them to become eligible for this, or are they eligible day one?
I don't believe there is a period of time. Now, if it's regarding a woman, I think you probably know that when you hire them. It's probably pretty obvious, but no, there is not. Yeah.
Okay, thank you.
Representative Lott.
Thank you again for bringing this bill. I know we've talked about it before, but I just want to maybe kind of go into these questions one more time, just because when you know that I have some disagreement on this, I'm going to
Sure.
be the insensitive one on the panel. But I want to make sure when I likely put my vote out that it is clear as to why. So again, you referenced short-term disability, and I know
That's
when we
right.
spoke before that there was some question as to whether certain people were allowed short-term disability. Was there any consideration into maybe making certain that we allowed a short-term disability benefit for those that don't currently have it?
You mean in lieu of having parental leave, that we would require short-term disability?
Not require. So short-term disability, of course, is what I did when I had my children.
Right.
It's an option. It's available, and it's personal responsibility, which is just something that I value,
Sure.
rather than the gift of continuing to do these sorts of things. So, is there a way in which we could have just improved our options for short-term disability versus extending the paid leave 3 additional weeks?
Well, you'd be welcome to introduce that bill, but I would not entertain it. And it currently is, that decision for 170,000 of our state employees is made school system by school system. And only 11 school systems have chosen to offer that. And generally the way it works is if you sign up, if you're a regular state employee or one of the 11 employee of one of the 11 school systems, you elect to sign up for short-term disability, and there's a waiting period in which you do not receive reimbursement for your salary. Although you could, if you had earned any leave, you could take it during that period, and then you pay a monthly premium. And but I just value parental leave. I value life. I value children. I value the bond that parents have, including adoptive parents. And I think that just as most of our peers who are larger employers, I think this is a needed investment in our employees. We are also, and I don't know that this is going to change anytime soon, we're having a very hard time recruiting employees. We're having a hard time keeping employees at the state level. We're having a hard time keeping teachers. And to be honest, I personally think it's disrespectful, particularly to mothers who have a newborn, that we would, as part of our package, not give them paid parental leave for a very short amount of time, which is 6 weeks, and including if you're an adoptive parent. And I think of short-term disability not as a reasonable alternative, but that should be used more for when you fall or you have you need an operation. And by the way, short-term disability does not cover adoptive parents. And so it would not cover this for a very modest cost to the state,
And so
according to Christine Murdoch.
And so just additionally, I will admit some insensitivity here because, of course, I do value that ability to have these options and choices available and for some personal responsibility, but I do worry as well that when we open this door, I know far too many people who have had to leave to take care of ill family members.
Sure.
And that is a regular occurrence. And those are sad cases. But all of that occurs as well. And so
Sure, it does.
to take something such as the choice of having a family and children, and I'm not taking that away from people, but in not all, of course, but in many, there's shared responsibilities. Either you have a husband who can do equal part, you have family members, grandparents, aunts, uncles, cousins. We've all done that. And I just want to make the statement. I do appreciate you because you do fight for women constantly, and I appreciate that. But I just wanted to put that out there that I think that this is crossing over just slightly, as well as I run a personal business, and we have had 7 babies in the last 5 years, and I know what that's like. But you say that we are, competing and we need to have our benefits plans up. It's very difficult to do. I need these same employees as well, and so do all of the small business owners around Georgia. So I do understand, but on taxpayer dollars, you are about to take all of my employees.
Well, I thank you for your comments and your perspective, or for sharing them. I would personally doubt if too many folks are going to choose to take a different job because they get 3 weeks more paid parental leave, but I understand your position.
I would just like to add, I respect Representative Lott. I think what you're talking about is the camel's nose under the tent. We hear it a lot, or the sliding slope. And personally, I'm sort of tired of it. I hear it a lot from lobbyists when they come in. If we listen to it, we would never take actions that are good for the citizens of Georgia. And I think one of the things that they leave up to us and we're supposed to do are make the hard decisions. I know that there are family members that have to work to take care of loved ones, but given the fact that the first few weeks of life are some of the most important that a child will have and a mother will have, and the bonding between family members is so important, any reservations that I would have on this one would be that this is the time for us to not worry about a slippery slope or the camel's nose under the tent, and support something that's very good for families across the state. It's a way to support women, it's a way to support teachers, and it's just a way to support families. And families are so important. You know, I'm an advocate for the aging. I will fight with you for anything and for the taking care of aging citizens. But we're talking about the beginning of life. And so that's just my personal, and I wanted to add it. And as chairman, I get to do that. And obviously, I'm in favor of the bill. Representative Fry.
Thank you, Madam Chair. Madam Pro Tem, thank you so much for bringing this. I literally just got out of a conversation on employee retention, and I think this sends a great signal that the state of Georgia does care about our children, we care about our families, and at the appropriate time, Madam Chair.
Thank you, Madam Chair, and thank you, Madam Pro Tem, for bringing this bill that increases time for parents to be with their newborns and recently adoptees or new children to the family. I do have a question for understanding. When you say rolling 12 months, that means that it can be, the 6 weeks can be broken up during the 12 months?
Yes.
That's my first question. May I have another question, Madam Chair? The second one, when we talked about the two-parent household, is it, you mentioned, I just want to understand, is it 6 weeks per each?
Yes, because they're two different employees.
Thank you.
I might add also that most daycare centers will not take a child,
Right.
even at 6 weeks, because they haven't had their first round of critical shots, usually until 2 months old. And so not everybody has family to help them bridge that gap. And so the 6 weeks doesn't get them all the way to their shots, but it certainly helps. And I'll just say this, we looked into it. Women are not coming back after 3 weeks. So nobody's budgeting for maternity leave. Yes, there's some cost because they still retain some of their leave and their sick leave and but it is not budgeted. If there is any funds, and it's a de minimis amount in the scope of it, it just lapses into their budget. And it currently, but they're taking it because of the FMLA.
Thank you. Representative Perkle.
Thank you, Madam Chair. And while I almost always agree with Representative Lott, when she said she's the insensitive one, when a panel, when I'm sitting beside her, I don't know. And I know she values life, she values children, and I'm thankful that she is a great friend and advocate for her people. So when you said they're not coming back, after
That's
3
right.
weeks.
That's right.
I mean, at all?
No, they're coming back, but they're taking unpaid
Oh, they're taking
leave.
additional
so
time, so they're
we're asking them
taking-
to be unpaid. And furthermore, if they do not have sufficient leave because maybe they had to take their vacation to take care of an aging mother or some other reason, they not only are they unpaid for that period of time, say 3 to 6 weeks or until they come back, they also, if it's unpaid leave, they come off the state health benefit plan and they have to pay both sides of their health insurance. To me, that is not a message that we value those women, those families, or those children.
Part B? Thank you. So I did love the camels under the camel's nose under the tent. I never heard that. I'm going to put that in my repertoire. But I'm assuming, so local education agency.
Right.
I hadn't looked up the 20-2-1. Is that charter schools?
School systems.
school
It would
systems,
include
so-
charter schools and school systems.
So it's not just, okay, so we're expanding that
because
just a little bit.
they're state employees,
Yeah.
but they also have some decisions like do they offer flexible benefits like short-term disability. That is a local decision. Just as do they pay the employer side of Social Security. That's a local decision. So they are state employees, but they don't have the same array necessarily of benefits that, say, a state patrol officer would have.
Okay, the balance of my questions I'll ask offline. Thank you, Madam Chair.
Do you need it? Okay. Chairman Perkle, I bet that the reason that you hadn't heard that before is because they don't have camels in South Georgia. So, we have a zoo up here, so they have a couple of camels. Anyway, last question, Representative Anulowitz.
Thank you. Thank you for bringing this legislation, and I'm glad that we had a lot of these clarifying comments, because I think it's important to remember, and we talk about this in multiple committees, but when we're talking about caregiving, chances are if you're caring for a new baby, there's a high likelihood there is also an older person in your life who you might be responsible for caring for in addition to your other children. And if you are taking your vacation time and taking other time to care for a parent or a grandparent or an aunt or an uncle, it's really important to remember that there's only so much time that we have, and I'm glad we're doing this because chances are caregivers are caring for lots of different folks in their lives, and when you're bringing a tiny baby home, that should and deserves to be your focus. So thank you.
Well, and I might say we have a couple members that we serve with who have recently adopted older sibling groups, and you want to talk about an adjustment in your family. Thank goodness there are families that are adopting older and particularly sibling groups that are very hard to place, and there's an adjustment period that I think this is an important investment in.
Well, and I want to give somebody a shout out down here before we go. Shelley has been one of the most persistent and most devoted and most active person trying to help people understand the need, how we need people to adopt the children in our care, and how important that is and how rewarding it can be. So to Shelley Hutchinson, Representative Hudson, thank you from my heart and from the rest of us on this committee. And I said I was going to cut off the questions, but will you take
Certainly.
more? They seem to have you questions. Okay, Representative Gaines.
Thank you, Madam Chair, and thank you, Pro Tem, for this bill. You may have already mentioned, I missed the first part of it, but didn't President Trump do some federal paid leave for
That's
parental leave?
correct. President Trump enacted 12-week paid parental leave for all federal employees, and thank you for reminding me of that. And I didn't mention that Representative Gaines carried the first half of this, which provided 3 weeks of paid parental leave for state employees
Thank you.
3 years ago.
Well, and let me ask you, Speaker, has that, sometimes we need to look back, just we went on expanding Medicaid for our pregnant and postpartum ladies from, 6 months to 12 months. Has the reaction and the cost and everything to expanding it to those first 3 weeks been a huge success and well received and not?
I've personally had teachers, when they learned that I was introducing this, talk about, you can't time the birth of your baby all the time. You know, it's not always in the summer.
And we're trying to
um,
prevent C-sections too.
And, you know, they're on all the time. We haven't talked about how important nursing is when you're able to, and how important it was for them to be able to take the time and not worry about making their house payment, even if it's just for 6 weeks, because they're in front of children every day. I mean, there's no break. And so I think this is another way of supporting, in particular, our teachers.
Okay. Representative Seaball.
Thank you, Madam Chair. Thank you for bringing this bill, Speaker. We've made great strides over the past 4 years in raising the salaries of our teachers in specific, but all government employees. And while we're not exactly where we want to be, I think this is one way to increase their compensation as an overall package. And just appreciate you thinking of this.
Well, thank you. I look at this in the same vein as I do the fact that we offer a state health benefit plan to our state employees, and the state makes a great investment in that, and the employer pays a portion of it. But I mean, I guess one could argue that we should make state employees pay both sides of it, and the state not factor any of that in. But I think that is a benefit that helps us attract employees, and frankly is, by a larger employer like the state, it is expected among the applicants that we have.
I'm going to take this opportunity to thank you too for shepherding what the governor wanted and the increases in budget for our teachers. I don't keep up with that on how much they are being paid, but I understand now we're one of the highest paying states for our teachers in the Southeast.
We do have the highest average and starting salaries in the Southeast.
Like that. So we do have that to be proud of. Always can do better on issues, and like I say, this is one of them. Representative Hilton, you are recognized for a motion.
Thank you, Madam Chair. Thank you, Vice Chair Gaines. Thank you, Speaker Pro Tem, for bringing this bill that demonstrates we care about our employees, we care about our teachers, and we care about life in this state. And I would like to make a motion to pass.
I have a motion and several seconds. Is there any further discussion from the committee? Is there anyone that is just dying to speak on the audience, and other maybe to all of you smiling out there, the ladies smiling in the group saying yes, 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 silently, of course. Okay, hearing no further discussion, everyone in the favor of the passage of House Bill 1010, say aye. Aye. Anyone opposed, no? We have one no. Okay, the ayes have it. Thank you very much
Thank
for
you,
this
committee. I
bill.
appreciate it. Thank you, Madam Chairman.
So, okay, and Dr. Ashley, I'm going to put you now last instead of first, if you don't mind. I'm going to call up the next one. Not last. After this one. Representative Daniels, this is House Bill 1037. You know, I told Representative Daniels that the only way I would hear her bill was if I got to hold a baby. You realize that little fella is our new House member. He even has his own name badge, that he's the House baby. And I will tell you, he's one of the baby. He usually is swathed against her. And 2 days ago, or I guess it's 1 day ago, I actually heard him make a little blah, 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 not screaming it, very quietly. And it was really the first time he doesn't cry. He's very happy. He is definitely what one would call a very good baby. He is getting a little more active. He doesn't totally like to be swathed all the time. You see little hands come up. You can't tell that I'm prejudiced about him, can you? I'm not a very good politician. I don't drink because I don't like the way it tastes. I don't like to have my picture taken. But I love babies and children. So now I have one that I can play with by turning around in my seat on the floor and making funny faces at him. And with that, Representative Daniel, please present your bill 1037.
Thank you, Madam Chair. So I am working from LC number 540297. Hope all of y'all have the same one. In a short explanation, what this bill would do is it would provide a commission on maternal and infant health in the state. So we currently have some other things that we've done over the years. The Maternal Mortality Review Committee is one of them. Before I even get into this, I want to make sure that it is clear that this does not replace that. It would be something in addition to that, because I think this issue is something that deserves the appropriate amount of attention. And I appreciate the work that they do and would like to see us explore it further. So the bill itself, there's some things I want to point out. So in lines 20 through 27, this is kind of how it sets out the appointments that will be made. So 6 members shall be appointed by the governor. Among those members, it would be required that there was an obstetrician, a pediatrician, or a neonatologist, a midwife, and a representative of perinatal facility. And so that would be up to the governor's discretion. And then 3 members would be appointed by the lieutenant governor for the Senate side, and 3 members for the Speaker of the House for the House side. The DPH commissioner would also sit on the board, or whoever they appointed to do so. And then the Georgia Research Alliance works with the university systems on a lot of other commissions in terms of how they seek grant money and things like that to do research. And so they are also included in this as a pretty standard across the board. And then the governor would appoint one of the members. So it's not an additional member, it's just one of the 14 members to serve as the chairperson of the committee. The commission would, the commission would meet at least 4 times a year at the call of the chairperson or upon the request of at least 7 of its members. So the members could, if need be, call for a meeting. And really the purpose of this and the difference that I believe this would provide is currently with the Mortality Review Committee, they are limited by confidentiality. They are working with medical records that people obviously don't want their information out publicly. And so I think that forming a commission would allow the legislature to have a seat at the table, per se, so that we understand on a personal level what these women are experiencing. Because not only are there women that are dying, but there are a lot of women that are sick. We are seeing a rise in the sicknesses that they are experiencing. And some of the efforts that we've put into place have been saving women's lives. And so I want to make sure that one of the things that this commission would require is that it is public in the same way that other meetings are operated. And so that the public is aware of the efforts that are being made, the differences that are being made, and where we hope to go in the future. Let me see if there's any. And then, it does have a sunset clause at the end, so it would be 2 years, and I did that intentionally so that if it shows that it is beneficial and it's not repetitive of something we already have, then we can extend that later on if need be. But if it is something that doesn't offer much benefit, then it would automatically sunset, and that way we're not committing to something long-term that's unnecessary. And I'll take any questions if you got them.
Thank you so much for bringing this bill and highlighting this important issue. I think this is great. One thing that I want to allow this commission to additionally focus on is I noticed that in terms of the designation of the types of medical representatives on this commission, that it does tend to focus on perinatal health providers sort of distal to the point of conception, meaning after pregnancy. And as all of us can understand, one of the prime determinants of the morbidity and mortality of pregnant women and infants is the state of health you're in prior to getting pregnant. So I just want to make sure that when we move through with forming this commission, that we also think about perinatal health in the sense of prior to pregnancy, because that really is probably the key factor in how well a pregnant patient does.
Right, thank you for that. Although I think there are 4 that were specified, there are 14 people, so I did not limit it to legislators. So the people that are responsible for appointing these people could choose to do that if they so saw fit. Thank you.
Representative, now you are talking about, there is an obstetrician that the governor's supposed to were you wanting to be more specific than that, or just?
Well, it could well be that women do not have access to care prior to becoming pregnant. So an obstetrician, by definition, sees pregnant patients. So just to factor into our analysis of how well we're doing in terms of dealing with our high maternal morbidity and mortality rates, that we're able to pull the lens back a little bit to prior to women getting pregnant and the state of health, generally speaking, for patients of reproductive age.
Okay, got it. Okay, who's next? Representative Anulowicz.
Yes, I thank you for bringing this to us. My question also relates to the appointments and the positions. And I didn't know if there was any thought given to our residency programs here in Georgia. Who, the doctors who are training the doctors, making sure that as we are training doctors, hopefully, if they're going to do their residency in Georgia, we would love for them to stay in our medical workforce. And I didn't know if any conversations had been had about specific to those residency programs and someone representing those residency programs.
Yeah, so you're correct. We have a ton of research institutions, and they, the review committee is actually formed of those people and has a pretty large swath in terms of, I think they work with the school, the Morehouse School of Medicine and Emory's public health policy program. And so and DPH also is involved. And so I believe that would be covered by inviting them to the table. The purpose of this is simply more so that we have the ability to understand in our policy making realm the importance of this and bring all parties to the table so that we also have the ability to ask questions, because currently we do not.
Representative Anulowicz, I would really question, putting a resident on such a committee. They're pretty busy.
No, I didn't specifically mean putting a resident on the committee. I just more meant someone working with, like, the people overseeing these residency programs, because they're the ones sort of figuring out what the residents are going to be looking for, basically helping make sure that they're being taught what they need to look for when we're dealing with these maternal and infant health issues. I don't think a resident specifically should be appointed. I meant more the people working with the residents, the physicians working with the residents in the training.
Okay, all right. Representative Bennett.
Thank you, Madam Chair, and thank you, Representative, for this bill. I'd like to follow up with Representative Owl's point about primary care and how a lot of the maternal mortality, the data and evidence show that it is due to a lot of pre-comorbidities. And so I would be interested in knowing if you would be open to adding primary care as one of the required appointees to the committee. And also I wanted to thank you for adding and including the midwife.
Absolutely. So I don't necessarily know that at this time it would be, necessary to add an additional person. At 14, it is a good group of people. When I was looking at other commissions and how many people are on it, we tried to find the good balance. But I will also say that OBs they do study general medicine. In order to practice as an OB, they also study general medicine. And so I believe that would be covered in terms of a knowledge that they would have.
I think I would like to make one, when the time is appropriate. I would like to be specific and ask the committee that we are very specific about that the midwife is a nurse midwife.
Yep.
Okay, and then I would add the word nurse on it. So, okay, at the time, and I'll make that
Thank you.
amendment. I really don't have a problem with adding a primary care physician. I think it might be a good idea.
Okay.
If you don't mind, and I'll put that in. It may be covered other places, but the primary care physicians, having lived with one so long who hadn't delivered a baby in 40 years, they have to be boarded every 7 years. And they are boarded, and they have to pass OB and pediatrics again, too, even though, of course, that opens up the fact that many of the primary care physicians do not. I don't know how we make it very specific. Let's leave that part open. Let's see what it does. We'll put a note into the speaker and stuff that we would like somebody, but it would have to be almost a primary care physician that still delivers babies or is involved in that kind of care, I think. Otherwise, you might have a family practitioner put on, I don't know, I guess just general help. Just not. Let me think about it when I make the amendment.
Thank you.
Okay, let's go. Representative Perkle. Is that who's next? Oh, Representative Lott. Sorry. Got.
Thank you, Madam Chair. Thank you for bringing this as well. And on this one, I'm a good bit more sensitive. I would like to say that for the record. Just curious and following up with Chair Lady Cooper, unless I'm misreading this, is there still a member within the governor's appointees that would allow for that person to fall within that category?
Yes.
For us to add that for the governor?
Yes, so he's responsible for 6 appointees, and only 4 of them
Are listed.
Yes, ma'am.
And so that would be maybe an appropriate place if the chair lady thought. I would do that if the author of the bill is open to that.
You would add a primary.
Yeah, primary care physician.
Okay.
I actually, the more I'm sitting here thinking about it, I think it's I don't know that it's hurtful, because
Right.
we do have rural areas in the state that they don't have an OB. They have
That's
primary
right.
care providers, and so they do deal with this.
Primary care or family practice.
Yeah.
Right.
Physician.
Right.
I just want it worded properly
wanna-
that,
Jody, you want to make that amendment and just add nurse in front of nurse midwife for it too?
Yes,
for me?
please. Would you like me to do that now or wait until?
We'll wait till after when
Okay.
but have it ready to go.
Yes, yes.
Okay.
And I will, and my point to you was actually in follow-up to some of that. I appreciate the way that you've written this. I think this is great. It looks clear to me, and I just want to see that your intent was that we were going to gather the data. It looks as though we were going to gather the data relating to the pregnancies and postpartum care and maternal mortality, of course, and the causes for that. And then I think on line one of these lines, but these recommendations, your intent was for those recommendations that then come back, and had they found something relating to a comorbidity or condition prior to even becoming pregnant, then that would also fall within those recommendations. Is that right?
yes, ma'am.
Okay, thank you for that.
Representative Hilton.
Representative Daniel, I just want to thank you for being the leading voice in the House on maternal mortality and maternal health. I appreciate the leadership you've taken on this important subject. This is established as a commission and not a study committee. This House and the legislature can be very good at studying things and putting them on a shelf. And with this is an important enough topic that we can't afford to do that. And so this is a little bit of an open-ended question, but I mean, how do we add some teeth to this so that it doesn't become another study that sits on a shelf, that we actually put these into place policy-wise and in practice?
Yeah, so, well, I don't bite, so I don't know about adding teeth to things, but I think the important aspect of this that is going to make a difference is the fact that we are going to be looking at maternal health in a more holistic way than we currently do. And I mean, I don't have to tell anybody in this room that the average age in the legislature is not childbearing age. And so I think that having people that can speak to that in the room to the people that are making the policy will fundamentally make a difference. And I mean, I think the teeth are going to present themselves when we start looking at some of these things. But this is also focused on infant health, and what we have a low birth weights. We have a higher infant mortality rate. And so this is kind of broadening the scope a little bit. And I hope that we as policymakers will take it seriously and do the work.
Let me see if I can get you a more specific. Megan? Could you come up to the mic? Okay. Identify yourself.
Hey everyone, I'm Megan Andrews. I'm the Assistant Commissioner for Policy at the Georgia Department of Public Health.
Okay, Megan, do we need to tighten this up any? Does this have enough teeth in it since it's going to be under your department and Dr. Toomey? Do you think it has enough teeth that we want it to function and we want it in place and moving?
Yeah, and I think it's a new commission. If there's opportunities for improvement, you guys come back here every year. There's the chance to talk about it again. And, you know, maternal health and mortality has been an ongoing topic of conversation since I've been at the department. So I'm
Well-
sure it will continue to.
Well, it's not only a topic, but y'all have instigated several new trial programs, have you not? And
Yes.
that are looking at this and
Yes, our
trying to move as much
programs
as you
at the
can.
agency are extensive with the support of the governor and the legislature. There has been multiple budget items or bills every year for the last 10 years.
moving programs. I mean, I
Yes.
know there's one down in Warner Robins where they, I think, assign a nurse or some, with a lady before pregnancy or.
Oh, the home visiting program?
Uh-huh.
Yes. So we have, and that was funded by you all last year and is being proposed to be expanded by the governor in his budget proposal for this year. That is where a public health, community health worker is assigned to high-risk pregnant women, and they go in and do home visits and serve as an extension of the clinical care of the medical provider. So these are women that are unlikely to go to their regular prenatal appointments. They'll do blood pressure checks, glucose checks, things like that to make sure mom is healthy. And if there's a concern, they call the provider. And they're looking at holistically at the family, not just the clinical issues with the mother, but are there behavioral health needs that we need DBHDD support with? Let's get her linked to pregnancy Medicaid and TANF and all the great programs that the state offers.
I think sometimes that, we pass bills and forget about them and then they're put into effect and we don't hear it. And then also we say we've got a problem and we tell public health to work on solving it. And I know that Dr. Toomey and Megan have been just focused on trying to improve reducing the number of near misses and also maternal mortality and premature births in the state. So I just wanted to point that out and thought we had those kind of programs.
Yes,
Thank
absolutely.
you
Thank
very
you.
much. Representative Reese.
Thank you, Madam Chair. I want to go back to the primary care physician. I'm glad we added that language in there, and thank you, Representative Lott, for your working on making that amendment. Because a lot of the issues that women deal with from a pregnancy perspective happens prior to pregnancy. And much of that health care need is with the primary care physician before the pregnancy become a matter. Sometimes pregnancy complicates those issues and make them worse than what they are. So I think that a primary care physician absolutely has a place on this commission, and I'm glad we're doing so. And I'm just going to take a moment to rise above the politics of all of this and not necessarily try to get pointers of who is doing what work and how it's getting done. And I'm just going to say I'm happy for the women of Georgia. I'm happy for all the black women who have died due to maternal mortality at 3 times the rate of white women. I'm happy for those women that live down in South Georgia who have been fighting for a long time to get access to health care. Now, you may be the face of the bill, and I'm so glad that you brought it forward. But at the end of the day, this is a great day for Georgia. This is not a political day. This is a great day for Georgia because we're moving forward with fighting for those who don't have the voice to fight for themselves. So I hope that all of us at this point can rise above the politics of it all and just say that we're working on behalf of the people, all 11 million.
That's all right. Thank you, Teddy.
I think, Teddy, you're probably right,
Representative
but boy, it sounded like a speech stump for me, but that's okay. It needed to be said. You can, are you preaching on the side?
No, ma'am, not yet.
Not yet. Representative Burkle.
Thank you. He was starting to get political there for a second. So, but I thank you for the bill. This is I am a big supporter of this. I think it's important. And I probably missed it because I was reading the bill. I didn't look at it beforehand as you were making the presentation. But this is not an ongoing program. So you establish a dream team, and please tell me if I'm wrong, to look at an absolutely important problem in the state, to come up with a solution. So it's defined in your bill, come up with a solution, and it's not a quick thing. You've got 2 years, and then it is dissolved. So we're not creating something that's going to keep going. This is something, let's get a dream team, let's look at it, and let's come up with a solution. And thank you for that.
And it will continue if the legislature wants to continue, if we show
But
that
not
it
with
has
this bill.
value.
That's right. That's
That it
right.
has value. Okay. Are you going to make a motion? Thank you. Representative Hilton.
I'm going to move for motion, but if I might, Madam Chair, to my earlier question about the urgency of this, on line 55, you have June 30th, 2026. Would you be open to an amendment that says they report their initial findings by June 30th, 2025? So, I mean, I'm sure this commission is going to be in communication with us, but I want to kind of tell them, hey, I want give us your initial findings within a year at least, so that we're not, I don't think we're going to be sitting around 2 years waiting for them, but just kind of put their feet to the fire a little bit more.
Representative, this bill won't, be signed into law to July. Then we have to wait for everybody to get their appointees. We'd be lucky if we had them by fall.
That's a good point.
You're really putting them into a
That's a good point.
push thing, so like that. Okay.
With
could
that,
you-
I'll make a motion, do pass.
Thank you. I have a do pass motion and I got a second. Okay, any further, okay, we have an amendment, okay, Representative Lott.
Thank you, Madam Chair. I would like to make an amendment to Representative Daniels' bill, LC 540297, and it is House Bill 1037. The amendment being on line 21, before midwife, add the word nurse. Also on line 21, after the comma, following the word midwife, add either a family practice or primary care physician.
Discussion on the amendment. Okay, can I have a motion?
Yes.
Okay, I have a motion to do pass on the amendment. Is there any conversation about it? Okay, everybody in favor of the amendment, say aye. Aye. Anyone opposed? Okay, we're back to the main bill. Okay, an amendment to move on House Bill 1037, now as amended. And I guess so we would be moving on a substitute, then moving on a substitute to House Bill 1037 as amended. Everyone in favor say aye. Aye. Anyone opposed, no. Okay, the ayes have it.
Thank
Thank
y'all.
you. And thanks for letting me hold our youngest member of the House. So, anyway. Okay, Dr. Ashley, please come forward. I am so sorry. But when the Speaker Pro Tem asked to go first, and then I didn't want a baby to be wanting to have an afternoon snack. So.
Thank you, Madam Chair. It's hard to beat that baby, so I know my place. So. But thank you very much. My name's Dr. Dennis Ashley. I'm the Chair of Surgery and the Trauma Medical Director at Atrium Health Navicent in Macon, our Level 1 Trauma Center in that city. But today I come to you as the Chair of the Georgia Trauma Commission, and we're scheduled to give a report to the legislators every year on the activities of the commission. It was interesting hearing this other commission that's being brought forward. So that's my role today, is to bring a report to you. But before I get started, I would just like to say I know all our hearts are heavy with the passing of Representative Smith, and so I really couldn't start without just acknowledging that and saying our thoughts and prayers are with you as well as his family.
Okay, guys, I've got a really important bill after this one. It's about Narcan and overdose, so I can't lose more people. Okay. You be back? Okay. All right. I'm sorry.
So today, Madam Chair, I do bring forward a report. I think I have some very positive news that you'll be very happy about. We're certainly happy about it, and it's time to take a victory lap for the healthcare providers as well as the legislators. When we work together, I think you'll see what we can accomplish when I show you on the next few slides. With that being said, I also have an ask that I'm going to bring forward to show what we need to do to maintain our momentum. This is a slide that shows the patients over the years that the Trauma Commission we were formed in about 2007, 2008. And you can see this is for severely injured patients that were treated at a designated trauma center. So this is an access slide. You can see in the early 2000s, only about 66% or about 70% of those patients actually made it to a trauma center. And these are critically injured patients that were not making it to trauma centers. They were dying in their local hospitals that were not designated. And you can see through the hard work of you and the clinicians working together, we've been able to increase that number to 93% of critically injured patients now make it to a designated trauma center. So this is a huge success for our state and an increase to access. Well, if you can get folks to a trauma center, you can improve outcomes. And this just shows you, this is CDC data. This is not commission data, but we made the slide from the CDC data. You can see in 2007 on the y-axis, or 2003 on the y-axis, the age-adjusted death rate. You can see in the teal line is the national average, and you can see for Georgia and for the Southeast region, we were above the national average or worse than the national average. That comes out to be about 16% worse than the national average. And that really is why the commission was formed. It's funny that I heard this discussion today. I heard these same discussions are very similar back in 2006, 2007, when we realized we had a mortality problem in the state with trauma. And the commission was put together through Senate Bill 60, now in Code 3111-102, that states that the commission is the accountability mechanism for the entire Georgia trauma system, and their job, our job, was to create a trauma system. So with that being going on for about 14 years now, we look back at the data. You see the last data there on the right side of the slide for 2019 from CDC. We have now bent that curve down to where we are 6% better than the national average. We are below the national average for mortality. And if you look at the Southeast region, they're still above the national average. So if you're looking, if I'm a legislator and I'm looking at surrounding states, or I'm communities looking at surrounding states, we're saving lives, and this is very important for Georgia. So I think as you look at this, it was great to hear the discussion about maternal mortality or fetal mortality in Georgia, which there are some problems there. I think what you're doing, we as clinicians cannot solve that alone, just like the trauma people could not solve this problem alone. It had to be a partnership between our legislators and our clinical community who are content experts. So I applaud you for really tackling another problem. And I give you a word of hope. This took a minute, but you can see the results of all the hard work for many people. And it's not just me. I get to give the report and face Madam Chair every year, who critiques my slides in great detail. But I keep trying to get better, Madam Chair. So now just to talk about it's time for a victory lap, but not really time for a victory lap because we've exceeded our funding. And I'm going to go through some funding issues here and some trauma center readiness because I'm forced to give a report to the legislators, and I need you to be on page with us. So when I talk about readiness cost, this is the cost of being ready to be a trauma center. This is not about insurance. It's not about Medicaid. It's not about indigent care. It's about what does it take for a trauma hospital or a hospital to become a trauma center, and what do you have to be certified or verified, if you will. It comes from the things in that the far right of your slide there, that little gray book. That's the Bible for a trauma center that tells you have to have about 100, 120 things to be verified. And so we actually looked at what the cost of all those things are. Georgia has led the way. The commission has led the way. You can see this is one of our first papers. This was presented at the American Association for the Surgery of Trauma in 2018, I believe it was. And you can see for a level 1 trauma center, it's $10 million to be ready. For level 2, it's $4.9 million. This is peer reviewed, published in the Journal of Trauma, and has been recognized nationally. So Georgia is one of the few states, really the only other state that has any data close to this is Florida, and that was published back, I think, in the late 90s. With that success, we went on to look at level 3s and level 4s. There was really no data for 3s and 4s, and these are critical hospitals in our trauma system. Level 3s and level 4s are less sophisticated as far as, or resource intensive, if you will. The level 1s are sort of like the aircraft carriers in the Navy, and you build around them as the system goes out. But the 3s and 4s are usually in rural Georgia, and they are very critical to our trauma system because they stabilize patients and then ship those patients on up the ladder to the 1s and 2s for really the highest level of care. And you can see for a level 3, the average readiness cost is about $1.7 million, and for level 4s, $81,000. This received, you can see this was presented in just 2022, and it's received a lot of attention nationally because legislative bodies across the country, as well as trauma centers, are really desperate for this kind of data because we just don't know what things cost. And it's hard to build a system if I'm sitting in your shoes or in your seat, not knowing what things cost. Now, to show you, this is a lot of data. This is really for your packet, but this is all in your packet. You have my slides in your packet. But I won't go over everything, but this is sort of from 2008 all the way to 2022, our budget for readiness costs. And you can see in 2008 and 9, our funding was $58.9 million. Now, that was a one-time allotment by Governor Perdue that came in the amended budget. At that time, trauma centers were threatening to drop out of the system. There was not enough trauma centers in the system. Our death rate, as you saw from the CDC, was astronomically high, and it was just not a good time. And that's why we were created to try and fix that problem. And Governor Perdue, as a stabilizing measure, put $58.9 million in the budget as a one-time allotment. And you can see, reading across the top part of the page, we had 4 level 1 centers, 9 level 2s. Our readiness cost at that time was $40 million for all the centers combined. And we were able to fund about half that, about $23 million, or at 58 cents on the dollar. That seemed to be, I want you to stick that number in your head, that seemed to be a sweet spot. It stabilized the system, and it started the momentum rolling to where we could go out and recruit other centers to come in. Now, if you fast forward to the bottom of the slide for 2022, you can see our budget through super speeder and through the firework tax. We don't get all of that, but we get a good percentage of it. Those two mechanisms are our funding source and generates about $23 million a year. You can see we have 6 level 1s now, 8 level 2s, and our readiness cost is right at about $109 million for all those centers combined. And we have, based on our budget, about $8.7 million to put in that bucket or that silo to fund readiness, which is about 8 cents on the dollar. So we've dramatically dropped down to 8 cents on the dollar for readiness. If you fast forward, next slide, to level 3s and level 4 centers, we didn't have data on them until 2019. And you can see, I'll go right to the bottom part of the slide, 2023. You see our budget again, $22 million. We have 5 level 3s, 5 level 4s, and their total readiness costs are about $14 million. And we can fund about $800,000 of that, or 6 cents on the dollar. So you can see that number somewhere between 6 and 8 cents on the dollar for our readiness costs. If you're a graphic type person, I think this tells the story. If you can just look at the lines, you can see over the years in sort of orange, you can see the level 1 and level 2 readiness funding has been sort of fixed. And as the years have gone on, our readiness costs have increased. You might ask why the big jump every few years. Our surveys that we've worked out to do this, and they are audited. We're very conservative and very tight on our methodology, and I'd be happy to go over that in great detail, but I won't bore you with it now, let you ask questions. But those surveys are so arduous that we only do those every 3 or 4 years, and that's why you see a spike at one particular. That's when we do the surveys. Now, when I come to you, I do feel the heat that when I'm talking about funding, I'm accountable to you as you are accountable to the citizens of Georgia for your fiduciary responsibility. So what I'd like to talk about is our performance-based payment system. The commission is not a bank, okay? We've built the system, but people don't get funding unless they prove that they are meeting the metrics. And on this slide, you can see to the far left, in 2010, for our performance-based payment, we only had 3 metrics they had to meet. We introduced the money at risk, if you will, or performance-based payments. We did it gently. Our goal was not to hurt the trauma centers, but to build a process where they were held accountable. And you can see on the slide on your right, in 2010, only about 10% of their readiness funding was held in that bucket. In other words, 90% they got, but 10% was at risk. Over the years, we've increased that now, following the left slide, the left table. 22 metrics, they have to meet 22 metrics to be qualified for their funding, and 76% of their funding on that right table is at risk. So again, they have to perform to receive their readiness cost funding. Now, uncompensated care, I'll just touch on that just very, very briefly, and the only reason I mention it is because through Senate Bill 60, we have to talk about readiness costs and we have to talk about uncompensated care, so I will give you a few numbers on that. You can see for our uncompensated care in an abbreviated format, spending less time on it, you can see at the bottom our funding for uncompensated care has been held constant through the years, and you can see that's continued to go up over time. And you can see back when we had the $58.9 million, we were able to fund about 61%. Remember, readiness, we were able to fund about 58%. So that number sort of sticks in your head back when we had that level of funding. But again, our uncompensated care funding, like the readiness, has gone down over time until now. To the far right of that slide, you can see we fund about 10 cents on the dollar for uncompensated care for our trauma centers. So sort of the take-home slide here before I switch gears, we're almost done. Our total trauma center readiness costs are level 1s and 2s, $109 million. Level 3s and 4s are $14 million. This is very tight. Again, I'd be happy to go through equations and show you how we did that. That's for another day. I'll be happy to come to your office and show you the details. But these are very conservative, tight numbers that I can easily defend. Uncompensated care, you can see this gets a little more messy, and that's why we've spent a lot of our time talking about readiness. But again, the commission is very tight with uncompensated care. You can see under that section, submitted charges by the trauma centers are $659 million. But as we know, centers can overestimate or inflate numbers. We're well aware of that, and we are very tight with that as well. You can see we only allow, through our equations, through our formulas, 10% of submitted charges. That's $70 million. So we do a 90% reduction before we even consider what we will pay for uncompensated care. And again, we have to pay some in that bucket because that's mandated by Senate Bill 60. So again, my message to you is that we are conservative. We are, I think, good stewards of the funding that we get. So overall, the total trauma center cost of readiness and uncompensated care is $194 million. So age-adjusted injury mortality, I want to come back to this slide and just show you some what this means. Obviously for life, it means everything. You know, if we saved one extra patient, then the 14 years that I've been doing this is worth it. But I have to wear different hats as I sit in the chair as the chair and answer to you, and you have to wear a different hat and be the good stewards of the taxpayers' dollars. So as we've moved that curve down below the national average, making it better than the national average, saving lives, that comes out to be 1,803 lives that were saved in 2020, that if the commission had not been available, if you had not worked so hard, if we had not done the things that we have done and over doubled the number of trauma centers that we have and increased access, we would not have saved those lives. Now, if we put on our business hat and look at the tax implication or the personal income, you can see to the far left, those bars to your far left, those 1,800 lives, this is what that means financially. In the short red bar to the far left, that is the money that was saved, personal income, by the averted deaths. It's about 1.3 million. The orange bar is, or the second bar is if you add in disability. You see the data there. And then the black bar, 5.4 billion in lifetime personal income preserved by saving those 1,803 lives. Now, if you look to the far right, I'll just go right to the point. That translates into $636 million in lifetime tax revenue preserved. That's what we want to get the point across. A dollar investment in the trauma system shouldn't be considered a cost. It really is an investment with a positive return on investment. I didn't really understand what a positive return on investment was as far as what the state looks at. So I started asking around, and I'm like, we knew that our return on investment comes out to be each dollar spent on the trauma system or on the trauma commission in our budget generates about $22.60 in return on investment. So we ask around, and from what I understand, one of the major projects that's been done here, the Savannah Harbor project, it had a return of $7.30. So we felt that we were in the right ballpark, we were headed in the right direction, that these tax returns were important. So what our proposal is, as I finish up, I won't read this whole slide to you. You have it in your packet. But you see on the far left the level 1, 2, 3s, and 4 centers. If you read, I'll just take the level 1s to make it very simple. Reading across the page, there's 6 of those. Their average readiness costs are about $10 million. Total readiness costs at $60. Our proposal is that we think, what is the right number? The state's never going to be able to cover all the readiness costs for these trauma centers, but certainly I think 7 cents on the dollar is too low. It doesn't allow me to go out and our teammates to go out and review or recruit trauma centers. It's hard to get somebody to come into a system, say we're going to give you a whopping 7 cents on that investment on the dollar. So what we are proposing, you see, if you add up all the cost at the bottom bold line there for all the centers, it's $122 million. We think a 50-50 split, $61 million increase in funding would pay 50% of the readiness costs for the trauma centers, 50% by the state, 50% by the trauma centers or the private sector, and we think that would certainly allow us to go out and continue to recruit and to maintain the centers that we have. So that is our proposal. This tells you really, and I won't read that whole slide to you in the interest of time, but it tells you the things that it would do. What it would do for you is the reason we picked readiness instead of uncompensated care is because it's tighter, it's easier for me to show the data. And as I come to you, as the commission comes to you and say, we can add on 3 more trauma centers, you as legislators can say, okay, I know exactly, I have the handout in my desk drawer, I know exactly what that's going to cost us, and it's just very tight. So with that being said, I just realized I forgot to introduce our excellent executive director here, Liz Atkins. I think you all know Liz. She has done a great job of helping keep all the commission members together and headed in the right direction. And with your packet, this talk today is boiled down into one pager. Really, it's a 2-pager, but it's front and back. That sort of goes over the key points. And then you also have the annual report in the other side of your packet so you can see how we spend all of the money. So, Madam Chair, you've been very kind, and thanks for allowing me to address the committee.
Okay, I have one question. Do you come before, or somebody from the commission, do you go and ask for this money from the appropriations chair? I'm still mad at him for sitting on my secretary. I don't even remember where he is. Okay, so somebody has gone and asked for the money?
We have, yes, ma'am.
So you're asking us to, as we have a chance to support the money for the trauma center?
Yes, we want you to know what we're doing as our yearly report. We want you to know that we've asked for an additional increase in funding, and we would like you to understand why we're doing that and what it would achieve. And then, as you hear, obviously we would like your support, but we have reached out to the appropriate budget committees.
Okay, and the object of the trauma center is to try to get coverage all over the state of Georgia where we can get people that suffer in a severe car accident to help within the golden hour when they're most likely to succeed, to live.
Yes, ma'am.
Is that it?
We want your trauma coverage not to be like a cell phone coverage, hot spots and cold spots. We want it to be consistent.
Are we any closer to having Phoebe Putney come into the system so that if ever our citizens are going to Disney World and Harry Potter Land someday, I want to go, we can say that we would be able to, get that kind of service within that part of the state?
It is my understanding, this is unofficial, but it's my understanding they have a site visit about becoming a trauma center, I think, in February. Is that correct? So they are, you and I have been doing this a while.
We've been doing it a while. So that is a major step.
Yes, ma'am.
Okay.
We also have had an ACS consultative visit, American College of Surgeons, so they want to move forward with that as well.
Great, because for the committee, that part of the state has been totally uncovered for all these years. But they're under new leadership, and I've been down there, and the hospital looks totally new. I mean, they're really, moving the ball forward in many areas, and I'm glad to know they're not leaving the coverage for trauma and becoming the trauma thing behind. Okay, that's all I would ask. Any questions from the committee? You got a question? Go ahead.
I'm going to ask you to break it down in simple terms for me. So the trauma centers are running about $200 million, $194 million shortfall. That is a question, yeah.
So let me go. You're looking at, I believe you're looking at the summary slide.
Yeah.
So that is
so of our 34
this
trauma
slide right
centers.
here. Okay.
Yeah.
So that's what, yes, sir. That their readiness costs are listed there, 1s, 2s, 3s, and 4s. What they have to generate to be, in other words, that's their cost. Yes, sir.
And then running that short every year. And so your proposal's then an additional $60 million on behalf of the state to cover a portion of that shortfall.
That's correct.
What are the trauma centers doing to close that gap?
So they, a lot of this stuff, when we did the surveys, we backed out, like we didn't let you count profitability. In other words, we had, anything that was profitable, we backed it out. So these are really their costs. And so that's the problem. That's when we're reimbursing 7 cents on the dollar, that's why a lot of centers won't jump into the system, because why would you jump into the system and take on that added risk and financial risk as well as, clinical risk for very sick patients if you can't have any better reimbursement. So that's my job as I hate to say salesman, but as I go out and be a recruiter for trauma centers, it's a little bit of a hard sell. And so that's part of why, we try not to be very emotional on the trauma commission and just be very analytical. And so that's why we've taken really 10 years to build this data to really come forth and ask such a bold, I understand this is bold, but we didn't do this the first 2 or 3 years because we didn't have the data. So we've been working hard to put this together, and I'd be happy to come to your office and show you exactly how that's, to show you the nuts and bolts, X and O's. But that's our dilemma, and that's our ask. Yes, sir.
Thank you. Just back to your slides on the uncompensated care, which seems like it's a huge portion of the cost that trauma systems have to bear that factors into the readiness cost. It looks like the uncompensated care burden is going up quite steeply, whereas the available funding is relatively flat. Would it help trauma centers to drop those uncompensated care costs by availing themselves of federal funding that is available to therefore drop your readiness costs and decrease the amount of state money that needs to be reinvested into the system to keep these trauma centers open?
Are you trying to say, would it help if we expanded
Maybe.
into...
I don't know. Maybe.
Certainly, if you, whichever, it's like a teeter-totter, you know, if you put more on one side or the other side, certainly if you have federal funds coming in, that offsets uncompensated care. It doesn't really affect readiness costs because we've separated the two out. They're two different buckets. So if uncompensated care, if I could wave my wand and make uncompensated care go away, that's patient care. So that solves one part. That's a good thing. Don't get me wrong. That we would love to have that. But then again, I'm still faced with readiness cost up front to get started and to maintain all those guidelines in that book, in that Bible, for being a trauma center. So I have to do both. Did that answer your question?
It does. I guess what I'm getting at is if the funding is essentially fungible and we're able to access increased funding to defray uncompensated care costs, which as we can see are quite high, that frees up more funding for other investments.
That's
Would
true.
that be accurate? Thank you.
Yes.
Representative Perkle, going to make that the last one. Oh, wait a minute. Oh, Representative Lott, I think you're first. Go ahead. Just fight over it.
Thank you. I got mine's kind of loud. And so thank you for presentation. The question I had about the multicolored graph as it deals to the 1,800 lives saved and the economic impact. It appears that you're using a $3 million lifetime earnings number, and that seems a little high to me. I don't know where you got your data from, and if it just seems a little high. I think the benefit is wonderful, lives saved are wonderful, but $3 million lifetime earnings seems a bit much since we have a different age gap. You're helping save some older people, some younger people, but $3 million overall, to me, seems a little high.
So just without getting too far down in the weeds, but working with people a little smarter than me in economics, we looked at you have to look at the lives that are lost, usually, but less than 65, okay, and just the way we did it, but less than 65 because they're in the workforce. Obviously, get down to kids or not, but less than 65, and then once you know about how many they are, did they die at age 18? Did they die, or were they killed at age 22 or
Sure.
age 60? So we did some modeling on that. And then once you sort of have that modeling of where those deaths occur, then you have to take into the account of the average or the annual salary of the average Georgian.
Sure.
And again, averages are off. Somebody might make a lot, somebody might make less as far as their funding. So that was factored in, and then you have to look at how long they live as well. So trying to put all those factors in there to come out with a general number, and that's sort of how we did it. But I think it's pretty reasonable. We could use ranges where we could use a low range or a high range, but these are pretty conservative as far as trying not to inflate any kind of numbers.
I just took the total divided by the number saved, and it looks like if you had a 30-year lifetime earnings ahead of you, you're at $100,000 a year, and that seems a little bit much.
Yeah, we used 51,000. I think the average, or what I think. Don't quote me on that because I'm trying to remember the paper right off the top of my head. But we used whatever I think the Labor Georgia Bureau average number for a citizen was.
Okay, thank you for what you do in trying to get this. We are certainly in a much better position than we were. How many years ago we've been doing this? 10?
I know there were some lean times. I remember those.
There really were. When people were dying on the roads of Georgia that could have been saved had they gotten to a trauma center within that golden hour. So thank you very much for what you've done. You have a regular job being a surgeon, and I appreciate all the other efforts that you do to try to help our whole state of Georgia. So thank you, and thank you for waiting to let the speaker go first, and then the baby's mama
All right,
go
thank
first.
you.
Thank you very much. And okay, everybody, we got one more thing, and let me follow up with you. You know that Georgia State has offered courses for us before, and that they have started doing dinners, and they're going to have one Thursday night, 5:30 to 8:30, and it's going to be a topic a lot of people are talking about. It's going to be navigating changes in Georgia Medicaid exploring predetermination and Georgia pathways to coverage. I really like, if you haven't been to one of those dinners, they, take a lot of input. They're going to talk about the programs, give you a chance to answer questions. And they do need an RSVP. If you need it, says legislative, Georgia, GHPC at gsu.edu. I'll get Audrey to send it out, but it's 5:30 to 8:30 at the Commerce Club. It'll be a good dinner, so you might want to go to one that would be dinner and learn, I get, instead of a lunch and learn. Okay, let's get this one over with. Okay, I have House Bill, which one have I got? 1035. Back in 2015, before we were really talking about opioids, just in the beginning, we passed the 911 bill, which says, and I can't tell people enough to get the word out still, that if a bunch of people are doing drugs, was usually our young people in college or high school, and one person gets in severe medical distress, if one of the people will call, that's from drugs or alcohol, if they'll call 911 and get somebody on the way to help, and if one person will stay with the person in distress and help them as they, or, turn them over if they're fixing to throw up so they don't choke to death, till the help gets there, we will not charge them, even if they're doing drugs or, drinking illegally, unless they're dealers. Now, if they were the dealer, all bets are off. And it has worked very well. It was also the first time that we talked about Narcan and beginning to get it out to our first responders and all. We've had a lot of changes that time. So what this deal does, it doesn't change the amnesty law or anything. It just updates what can be happening, what the standing order from Dr. Toomey can be, and how she can, order all the different new antidotal type drugs that are coming out. Narcan is not the only one now. We have drugs that are coming out that have a longer half-life. Because one of the problems we're running into, you have somebody that is in distress, you give them the Narcan, they seem to be better, you let them go home, or you say, you're okay this, and family watch them, and an hour and a half to 2 hours later, they have a relapse because the Narcan doesn't last enough. So there are all these new drugs. It expands what Dr. Toomey can do, what she can order for the standing order, and where they can get it. They can also now, get it over independent pharmacies, and not over the counter. It also, brings up to date the amounts and so forth, and her ability about how it's packaged. And then the other thing, and I hate to even bring this up, it kills me because it shows how bad the problem is getting. Emory came to us from the colleges. Emory is to the point where they are trying to take care of the kids on their campus, and they want to use vending machines to dispense antidotal medicines for, when there's an overdose. And it was illegal to use vending machines. I'm sure Emory won't be the only college that uses this once we update this law. I think you will find probably vending machines on all our college campuses. And the law allows for that. And that's basically what this law does. It's an update of making that where we can have vending machines and what Dr. Toomey can okay through her standing orders and all. Okay, hit me with questions. And okay, let's get the public health. Come on, Megan, in case and answer questions for me and anybody else that wants to. Emory, where are you? Okay, here we go. All right, questions. Who's on? Okay, Representative Lott.
Could you just explain further, Madam Chair, please? How would obviously I think this is a great bill. So I'm back to being sensitive. Okay, I'm gonna try. So great bill, no objections. Just very curious as to vending machines because my concern, and I'm probably way off on how this would be done, but in the vending machines that I used to use years ago, but I would think if that was a free option, people would just be pulling them out. So how does this work?
I have not seen one of these vending machines, and I'm going to turn it over to the representative from Emory.
Yes, so I can speak to that. My name is Sydney Wilkins.
Puts it on.
Is that better?
Yeah.
Okay. My name is Sydney Wilkins. I represent Emory. So we have an addiction center that is under our School of Medicine. It is in partnership with Hazelden Betty Ford. And that's the only place that we have a vending machine as of right now. So if you go to the addiction center, you're correct, Representative Lott, you just press the button and naloxone or the Narcan comes out. The goal is to eventually have this at all of our hospitals and across our campuses, including our Oxford campus. So the main barrier that we have is a provision that would hold pharmacists potentially criminally liable or endanger their license if they fill up those machines, which is a huge barrier because we can't have just one person obviously driving all around trying to fill up those machines, but you can just push a button and get it.
And what it does, it also allows pharmacists to do this and to fill the machines and gives them immunity for, filling it.
Yes.
So that, and the pharmacy board would make that rule. But Representative Lott, I don't know that there would be a way in the vending machines that you would keep somebody from punching the thing and.
But I also think that we would rather have someone maybe taking too much and us having a pharmacist have to routinely refill than have a overdose.
So this leads me to a more of a point than a question, but this is a really pretty exciting concept, and I think if you would get with some folks at Georgia Tech, we could create like an AED sort of box, but
there are people who've asked me to get that bill. Will you carry it when it?
No, I think that's a fantastic idea. I think it should be
Okay.
accessible. I think it should be like everywhere that you need it, have a separate point. But of course, in doing so, the technology is such that, and this would be my request. I know that there would be some people saying that's a limitation, but you would have to either scan your ID. Or scan a credit card or scan something so that you are identifiable when you're pulling it out. So it's not so easily accessible, but this is a great concept and I'm completely for it. So thank you for your time.
Absolutely.
Representative Lott, okay, and that's something to be discussed. I don't know. I think people, I'm not sure people would use it if you do that. It was like when we had and passed the bill about dropping off babies. In all the safe places that we had. Do you remember this? Or maybe before your time, we were saying you can take them to the fire stations, you can take them to the police thing. And women weren't doing it. They were still leaving them in the woods because they didn't want to have to give their name. And we had said in the law that they had to give their names and all. And until we changed that,
You're right.
because they don't want to be identified. And I'm figuring these kids aren't going to want you to know that they're on opioids or that somebody they know is on opioids. And I will say that the Center for Addiction is not very accessible.
No,
so y'all need
you
to get
have
the
to go
vending
through a forest
machines
to
out
get there.
much more accessible than just right at that location.
Yes.
Okay.
So the hope is to eventually get it more on a central location on campus, but as of now, it's just on our addiction center property.
And I hope it's not like it used to be with us in Georgia Flags. I had 3 Boy Scouts. We don't give us flags anymore, and they used to give us flags free, state flags free. They're now $50 a piece. And if you want to give them to your Boy Scouts, and you know why? Because so many of the fellas, legislators, went and hoarded them. And they would get 25 and 30 of them at a time. So they took them away from all of us. So I would hope that people would not empty out the machines, that they might care a little bit more about their fellow man than that. In fact, I did get 3 flags this weekend because of my new AA, and she went and found a machine. She knew where there was stashed that nobody was using here in the LOB, and she got them for me, and it's a good thing because guess who showed up? Former Governor Perdue. His grandson was becoming an Eagle Scout, and I gladly turned over my job of presenting the Georgia flag to him to the former governor. So thanks to my new secretary for doing that. Representative Al.
Thank you, Madam Chair. I think this is a great bill, and I think it's part of a bigger push nationally to make opioid antagonists more accessible to people, right? The first thing that they did is they made it, the FDA made it available over the counter, so you don't need a prescription to get Narcan anymore. So that's the first thing. That's a huge barrier. Second thing, I think that having a vending machine really takes advantage of the fact that it is over the counter, right? It maximizes the effect. And I think to Representative Lott's point, and what we've been talking about, the anonymization of the access actually is a huge improvement in access, because we realize that opioid addiction and opioid use is stigmatized, right? So for people to not avail themselves of risk mitigation techniques because they're afraid of being tagged or criminalized or, stigmatized in any way is another huge barrier. The third thing I just want to bring up is that Representative Lott brought up the fact of making opioid antagonists available just like we have AEDs. We actually do have that. We have boxes, I think, around the Capitol. You can see one right when you come in on the first floor for the public entrance. There's a white box that says opioid reversal, I think. And I believe there's at least one other one in the cloakroom across from the House where the AEDs are kept. So these are measures that I think that this body is taking to make it more accessible, destigmatize it, and to really increase access.
Representative Lott, I am covered up with bills. Mr. Breedlove is back here. He brought a gentleman with me. They want boxes in other buildings, federal, and could they talk to you, please, and see maybe if you can rustle up a bill? Could you do that for me? And that kind of thing, because it is a good idea. And I saw right as you go past the police where they are, it's in a box. They brought that type box, if you can do that for me. Okay, Representative Perkle, you got another question?
Yes, ma'am. And I know there's at least 4 in the Capitol. I know Representative Lott and myself have gone around to find those. We actually had a conversation about that. And I would like to say, of the hoarding of the flags, you were looking this direction. For the record, you were looking at my friend Gaines over here. So I'm not the hoarder. This is your best bill. I really like this. I actually keep opioid antagonists in my truck. I have them in my truck. I have them at the house. And I have no idea of anybody that I know that is an opioid user, but I want to be ready. I think we should make it very accessible. And anything that can provide immunity from civil liability, I'm a big fan of. So, tort reform. Thank you.
A remote automated medication system. Isn't that one that some of the hospitals use? Who's here from the hospitals? Okay, thank you.
It's like a vending machine for medication. So I believe what that does is that it feeds the information about the stock in the Pyxis machine or whatever to the central source. It was like, you only have one left. It's empty, refill it. So it just conveys it to the stocking place.
Right there. That take care of it? That take care of it? I think they use them in nursing homes sometimes. When they do several nursing homes, it does let them know. So, okay. We have 2 people that are signed up if they want to speak. Mr. Ryan Miller, if you want to, or Ryan Miller.
Thank you, Madam Chair, members of the committee. Ryan Miller with the Georgia Hospital Association. Just wanted to go on record saying we support this bill. Thank you, Madam Chair, for bringing this.
Okay. And Jeff Breedlove.
Thank you, Madam Chair. Jeff Breedlove on behalf of the Georgia Council for Recovery and a person in long-term recovery. Just want to go on record of support of this bill. Did want to just answer or comment. I've had the privilege to see this vending machine in question at Emory, and it is a wonderful machine. It is not on the main campus, but it's just down off Clifton. And we've had meetings with folks, and I know I have permission to say this at Georgia Southern University. They're looking at ways to do things. Other universities are looking at ways to get these on campuses. And I know this is not just about colleges, but because we were talking about Emory, let me just remind you all that according to the federal government, the leading cause of death in the United States of America for Americans 18 to 45 is fentanyl overdose. So to Representative Lott's point,
anonymity is important in this. We have some places across the state in your districts where there are opioid antagonists accessible for free. It's been a blessing to get to know folks all over the state. We've never had any complaints that people were stealing them or taking them. So that's not been a crisis we've been concerned about, and I don't think it will be a crisis here. I do think, the work that we will implore this good committee to keep doing is to find ways to further expand them to more places. So we've not heard of any problems of people taking them inappropriately, and we of course have examples where they have actually saved lives. So we thank you for this leadership and hope that you will do a due pass.
The other thing is that these are not cheap, and this allows Emory or the college to deal directly with the manufacturers, not having to go, so that they can try to get a discounted rate to fill these. And so that's also helpful in trying to make them, available. Anything we do, and also that would help people that are giving it out in the communities and all. So sometimes we just need to update bills, and this is what this one does. So, Representative Hilton, you seem to be my floor leader today. I didn't know. I'm teasing.
A floor leader every day. I don't have any flags or camels, but I do want to make a motion. Do pass.
Okay, I have a motion to do pass on House Bill 1035. I've got a second. Is there any discussion? Here, I know if I'm seeing that no further discussion. Everyone in favor of the passage of House Bill 1035, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. Thank you to the committee. And please consider going to that dinner on the 1st, Thursday night. If you want to know more about the debacle that has happened in trying to get people re-upped for Medicaid and all that, and also looking at more coverage.